All right, so let's go ahead and get started. So, good morning, good afternoon, everyone. Thank you for joining. My name is Aaron Fulner with Invent Health, and I'd like to welcome everyone to our February roundtable. Our panel of industry experts today will be discussing the strategic insights that Medicare Advantage plans need to have to navigate the myriad risk adjustment challenges coming in 2026. I am joined today by our guest speaker, Mark Bigelow, who is the VP of Risk Adjustment at Cambia, along with our Chief Product Officer, Siva Tunga, and our founder and CEO, Rohit Bhardwaj. So let's go ahead and jump into the topic. Rohit, would you like to start us off and talk about our agenda?
Yeah, thank you so much, Mark. It's a pleasure to have you join our roundtable this morning. And thanks, Aaron, for putting this together. I think every month we're trying to talk a little bit more about what's changing in the ever-changing risk adjustment space. And I'm excited to talk a little bit more deeper about the changes that are going to come the following year. And some of these steps that we have to take is the time probably could be now. I think that from an agenda standpoint, definitely we want to talk about a little bit more about mastering the V28 risk adjustment model. And I think I was talking to Siva, our product officer, earlier, and he told me that we have ever since 2020 gone through at least four of these model changes, right? So it looks like this is not a one-time event anymore. So it's going to be like kind of our risk adjustment process going forward. And second thing is kind of correlated to it, right? So optimizing some of these operations for the new normalization factors, right? So how do you bring that and cope with those as a second step? And of course, the third is that adapting to the new SEC coefficients, right? How's that looking like? So I think just to kick off this discussion today, Aaron and Mark and Siva, I feel that probably we need to start discussing some of our preparations and what health plan should be looking at. So I think I'm going to pass this on to Siva for now and see what he thinks about these points. Siva?
Yeah, thanks, Rohit. Hello, everyone. As we know, I think the V28 risk adjustment model is already in a blended factor. We are going 100% next year. And what does that mean is, right, we need to look at what are the key enhancements which have been done with the V28, or we call version 28 risk adjustment program. The first thing is it restructures your HCC categories and consolidating and expanding the conditions. So that's where you can see more chronic conditions or removing low impact conditions that primarily are influencing your risk adjustment programs, because there were, as you can know, that more than 2,200, like the numbers are going to change as CMS updates, are eliminated from your V28 model. That's a big change. We can talk about some of those things as we are speaking from an operational impact standpoint as well. There are certain conditions which have minimal, as per CMS, they have minimal predictor value from a utilization standpoint, and they kind of removed them as well. So there are nuances, there are certain conditions which they explicitly removed it based on their utilization and Medicare Advantage data reporting submissions for CMS as well. So it's important for us, we kind of understand where the changes are occurring and how or what type of programs you need to run as we are transitioning to 100% V28.
Yeah, in fact, from an operations perspective, it's really important now with the fewer conditions and the importance of these conditions that execution has to happen in a much more precise way. We can't afford to miss anything, right? So every member that you target, you need to do everything you can to engage them. I think we're used to things like in straight MA, something like a 20% in-home assessment rate of who's targeted. Well, not only do you now have to maybe refine who you're targeting for in-home assessment, I think we have to think about, is 20% an acceptable outcome anymore? If we really think those members need an in-home assessment, I don't think we can accept 20% anymore. And so member engagement's got to be refined and improved, and we've got to work to make sure we're not overwhelming the member, but that we engage them meaningfully. Similarly, every condition has to be addressed. I think we're used to things like maybe addressing 75% to 80% of the conditions. That's no longer going to be acceptable. And so we've got to make sure that everything that we can do to have accurate data to start with, and that we follow that data throughout the process and do everything we can to improve precision and completeness happens. These risk scores, the margin for error is gone, and these risk scores need to be more complete and accurate than ever. Another thing that I've noticed is that my sense of what's normal has had to shift a little bit with just straight V28. Like the bellwethers that I had, or the heuristics that I had in my head, are off a little bit now because the number of conditions is less. So HCCs per member, HCCs per visit, those things are all going to change a little bit. And so just kind of calibrating our sense there. And then lastly, I'll just say from the provider side, they're going to see a lot fewer conditions, which is a good thing, right? They'll engage maybe a little bit more. It'll impact their incentives. So if they've got a % conditions addressed incentive, they just got a little bump because there's fewer conditions in there for them to address year over year. And so one more condition addressed makes a bigger impact on that. So just thinking through what this means to all of your operations and is what we're all doing. And so it just becomes much more important now.
Wow. Now, those are some great insights, Mark and Siva. I think one of the things that I had noted in my mind to ask both of you is that where are you seeing customers asking most? And this is more of a Siva questions, right? Most of these health plans asking for help, right? Is it more on the chart chase that has to be now impacted more than impact assessments have to be done more diligently? Siva, what do you think? And then Mark, like you, I think you already highlighted the need. So it looks like the providers probably also everybody has to tighten their game, right? So provider might have a little bit of a benefit of the condition because they might have to, capture a little less of these conditions, but they're incentivized and everything else goes well. But I think, again, it has to be well-oiled machine. Siva, from your perspective, what health plans need to do more in this scenario?
Yeah, it's a great question, right? In terms of what we constantly hear from them is how do we update my target list? It starts from a perspective where you're looking at the beginning of the year or at the early stages of the year, which providers I should really target associated with that. The biggest challenge what we see is because of the shift, there is a variation in the utilization patterns, and also you could see that the variation in which providers you might need to more target, because you might have more specialty alignment now more because there is more granularity in the ICD codes which need to be specified, or more HCCs are there. So that nuances are coming in, and where we see is we want HCC recapture rate, target list refined based on my providers, more important providers. The second one is the analytics projections, how we are calculating, because the programs what we have run previously might have yielded good results for V24, but does it work the same way for V28? People are really looking at what kind of metrics I should build to measure those for success in 2026.
Yeah, that's exactly right. I love that you called out specialists because, with V28 now, behavioral health is going front and center with things like just behavioral health conditions there's more behavioral health conditions in there. And there's a stigma still in the industry about documenting these conditions. And I don't think we can accept that that's okay anymore. I think there are health plans that aren't passing those conditions on. Doctors who will not document them, members who get care from doctors who don't document in their EMR because they don't want these things out there. And I think it's going to impact these payments in a dramatic way. And so I think that's another thing to think about is based on the new conditions, what new engagement programs and education programs do we have to be successful?
It's a great point, Mark. And I think that's a segue to our next section, right? Where I was about to talk about a few things, which is kind of leading from you and Siva. So it looks like there is a lot of education and interaction that is needed between payers and providers going forward, right? So that could include education and training, data analytics and reporting adjustments, right? And will the customers, or I keep calling customers, but if these are health plans, need more of customized reports going forward, right? So you're used to certain kind of reports right now, but would this change need to have some customized reports? And what are the operational adjustments that we need to make, right, going forward? So, Mark, I think since you brought this point, I will go back to you. So what are the some of these educational programs do you think will be very effective?
Yeah, thanks. Yeah, I think one area is specificity. A lot of the specificity training we do is going to go away. We don't have to have providers coding severe diabetes or diabetes with complications anymore because it's all the same. Same with PAD, except for with PAD, it's actually a little bit more severe. Most PAD screenings can go away. So we don't need to encourage our in-home assessment vendors or our providers to screen for PAD as much. I think from a clinical perspective, I think that still makes a lot of sense. I would hate for a provider to stop screening for PAD if they thought it was clinically indicated. I don't think they would, but I think from our perspective, we don't have to track that anymore. But I think there's new screenings that are critical now. And so when I was on the provider side, when V28 was announced, and one thing I noticed was the plans that were kind of leading the way, or the groups that were leading the way, implemented screenings around these new conditions right away and tracked what percentage of our patients are indicated for a screening versus how many are actually getting them. And I think if health plans can do the same thing, start working with providers to agree on what criteria are relevant for each screening and track the application of those screenings, I think that's a great way to make sure that your operations are set up to be as complete and accurate as possible for getting these conditions.
And I think you see a role of analytics in that, Mark. How will that pan out to be to help this education, further this education, or come up with these reporting and operational adjustments?
Yeah, I think it's I mean, risk adjustment is obviously a data exercise at its heart, and so analytics is critical for this. I think there was some, like I said, margin for error before where you could have maybe a little bit of a gap in your analytics, and I think that's all gone now. I think everything we do has to be based on data and on really tight data. So, for example, health plans are a great repository of a holistic view of members' care patterns and some of their health. So, using that to determine which members you would want to leverage screenings for, I think is a great thing to do. But also, I think getting into the details of how providers are coding. So, these new conditions, particularly, what is their agree rate versus disagree rate for recaptures and suspects in these conditions? Normally, you would want to track that anyway, but with these changes, it's critical now to understand our providers learning how to document these new conditions, and are we training on those new conditions? And particularly important with that is how do they sit relative to their peers? It's not just are they disagreeing too much? It's are they outliers in terms of how much they disagree or how much they agree? Using that as the guidepost for how you do your education is really important.
Well, that's great, Mark. Absolutely. Now, Siva, what's your take on some of the true essentials, right, when it comes to practice modeling?
Yes. One of the things which, like, we keep specifying now that we have to do some kind of a provider specialty and practice specific modeling has to be done, because it's I'll give a great example for this one to kind of people know. A patient with type 2 diabetes, peripheral vascular disease, and protein calorie nutrition, next year his risk score is going to drop by almost like $8,000, because peripheral vascular disease and protein calorie malnutrition is no longer risk impacting. All of a sudden, a patient with diabetes and persistent asthma who was at a very low priority in V24 becomes more valuable for health plan to target. Now, the type of population mix with respect to risk adjustment need to be adjusted, where people need to see that where the drop you're going to see, because CMS when they do the analysis and they project, they say there will be a 2 to 4% variation across the health plans. But now, when we go by specialty specific, population specific, or plan specific, sometimes that number is going abnormally high, 10% higher, 10 to 12% variation. And some plans do not have an impact because, let's say, if you're targeting very sick population like a DSNP population or very ESRD population, the impact might be a little different compared to a straight Medicare Advantage MAPD population whom the members are being treated. So it's very important that when we do the analysis, what type of data points you need to look at, analyze, and
Yep.
and what conditions are changing. Because even though CMS introduced 268 new conditions in V28, what we have seen is more than 40 to 45% of those conditions are never reported in some of the plans. So what does that mean, right? You need to look at those type of analysis when we are talking about how to do the modeling associated with the risk impacts.
No, I think this is a great point, and I think ties back to what Mark was saying, that there is very little now room for error going forward when it comes to data exchange between providers and payers, and then what you submit for reimbursements, right? So this whole ecosystem has to be managed in a very different way, and you got to be very diligent. And then your understanding of the new SEC codes, and also what's the impact on actuarial values, right? How do you accrue? How do you forecast? Because that's going to change year on year now. So predictions will be very important. And then analytics would play a big role because you need to know beforehand which are the members that I need to focus more, because I will, like you said, there's a drop of $8,000 at the condition level, right? So I need to know that because I need to accrue that, right? And I need to create a case about it. And what else do I need to, button up myself to be able to, make up for my lost revenues or opportunities and so on and so forth. So these are great points. And I think you rightly pointed out also on the proactive monitoring, right? So what are the things that we can proactively monitor, Shiva, when it comes to help some of this leakage?
So the work has to start, or should have been already started, like last 2 years data. You have to look at it and see what the potential, how the V28 transition. Typically, we look at it from a payment year 2026 impact, but we need to start always 2 years back, because most of the times CMS is a retrospective model when we are talking about risk adjustment wise. And it's always important that you're running 2 years programs, 2 years in parallel. So where the proactive monitoring comes into play is which population you need more focus on, because my chart chase target list, my in-home assessment, my HRA, or my any member provider engagement now need to have two versions of it. Because you're still working on payment year 2025, you also need to work on payment year 26. Now both have a different case mix population whom we need to target. Those nuances need to be there for health plans, even providers, to know this is changing, because all of a sudden, if provider sees their risk scores are dropping, if you're in an at-risk model working with the provider, then there is a risk for them. They don't anticipate that, and they need now to plan and work with the payer what kind of additional incentive programs they need to work on for the V28 transition as well.
Yeah, so I think before I go to Mark, and you brought some of the important points, Siva, right? I think you are also referring something to, so there'll be an adjustment. So if some of the health plans do not have, let's say, technologies like NLP, so there will be some kind of adjustment on EHR and NLP enhancements, right? Because they have to do some more documentation checks as the data gets into a payer's environment, right? So they will probably need to be more proactive. And I think it goes back to Mark's earlier point about provider education, right? So should there be some kind of quarterly provider performance reviews that could be driven again by analytics, right? Like you rightly pointed out, if I have already stratified member and payer list, a provider list for you, you should be able to come and have those quarterly reviews to be able to perform these, including some of the audits, right? Provider documentation audits that need to be a part of this new normal, if you will. Right. Mark, I want to come back to you on some of the implications of the payment transitions, right? how would these implications, according to you, looks like? Right, and we talked a little bit about the actuarial values, but I'd like to hear a little bit more.
Yeah, from my perspective, yeah, I think that what I noticed when this was first announced, and I think is still true, is your upside from risk adjustment overall is a little bit, the ceiling is lowered a little bit. It's most plans are not operating at their ceiling, so I don't think that's terribly painful in the near term, but I think the potential for increases is much lower than it was. And so for a lot of plans, just understanding that your ROI probably just took a 4 or 5% hit from where it was just yesterday. And so just like Siva mentioned earlier, recalibrating the programs that you're doing and who you're targeting based on that is really important. I think getting that message out to provider groups as well is really important, especially the ones with an APM that has any kind of a tie to premium, letting them know that this is what the impact is and how we can work together to make sure our risk scores are more accurate and more complete than they were before is critical.
Yeah, that's great. So it looks like it has to be a very coordinated effort between payer providers, and education plays a key role both ways, right? Across board, both internally to payers and to providers. And maybe there has to be some kind of an agreement between payers and providers about this quarterly audits or provider education, and how can we make it more impactful for both sides to benefit out of the situation, right? So, uh, but I think, Aaron, from our perspective, at a high level, I think we have covered what we wanted to discuss and sensitize about this key topic about version changes. Both Siva and Mark, I think they have exchanged their views with a broader audience. So I want to give it back to you, Aaron. Thank you.
Yeah, sure. Thanks, everybody. I appreciate that. Let's go ahead and transition to the next slide. So really want to thank Mark for joining us today. Thank all of our speakers, Rohit, Siva. Appreciate everyone's time. If you do have any questions from the audience, please feel free to drop those in the chat. We have already received some questions, so let me pull those up and I will pose those to our speakers. So the first question is, what are some of the most significant analytic updates that are needed to identify and address potential gaps in risk adjustment reporting?
Yeah, I can take that one, Mark. Yeah, I'll wait for yours because you have more experience in these ones. What as when we are working with multiple customers, what we see is more in terms of what the projections, how to model the projections with respect to the V28 transition when we go into 28. That's one. The second one is my target list, because the target list itself needs a refinement overall from a population perspective as well as from a provider perspective as well. So that's one area where we need to refine the analytics, and as we learn, we have to keep updating those in the system.
I would just say from my perspective, I think the other thing, I separate reporting and projections from operations, and I always try to prioritize operations, like assessing conditions first. So from an operational perspective, I think it's critical to get the model updated and the reporting, the targeting updated as quickly as possible, and really try to create member profiles now around what type of engagement is going to make the most sense for that member and will be most successful in addressing their conditions. And then I think second to that is taking that data and then refining your projections around what risk score is feasible and what the ROIs will be.
I think that's great insight. Appreciate both of those viewpoints. So another question from the audience. So earlier in the presentation, we talked about adjusting to the new normal. So this question relates to that. So what are some of the key initiatives that need to be updated in payment year 2026 to align to this new normal for risk adjustment?
I can take a stab at that first. With the reduced ROI of a lot of these conditions, and knowing that there are some conditions that kind of trend towards being captured in certain areas. Like one example is in-home assessment, right? Pad screenings are really common in in-home assessments, but they're not necessarily in the office as much. That's all gone now. So the value of an in-home assessment is probably going to take a pretty decent sized hit if you don't change your targeting. But if you're targeting the right people, particularly people who can't get assessed or won't get assessed any other way, then you can still keep that ROI pretty healthy. And I think by leveraging the unique things that can be done only in the home, like fall risk, understanding how pills are being stored and used, and having the clinician help with that, those kinds of things, you can still, I think, have a meaningful impact on patients' lives through in-home assessment.
Most definitely.
Yeah.
Siva, would you like to add in on that?
Yes. To add to that one, I think one area where we need to look at is the new HCC codes, which are added as well. They're more granular because previously they were at a high level, now more granular. That means more specificity, more documentation is required. Like, for example, patients having prosthetic limbs, amputation is only now acute. But now if a patient has a more prosthetic limb, typically doctors do not capture those more predominantly. It becomes more and more important to capture those. So there are certain areas where you need to focus on how you can get more granular when you talk about, when that's what we call it as a new norm. Now the shift has changed, now more specific in certain areas and less specific in certain areas. So now you need to adjust or recalibrate in both aspects when we talk about payment year 2026.
Makes sense. Thank you, Siva. So our last question from our audience today is, with regard to provider education, which we touched upon earlier in the presentation, and prospective risk adjustment programs, what are some of the things that plans need to do to address these areas, in conjunction with the new normal, or what are some of the things that they can do to optimize these operational areas?
From my perspective with the education, we talked about this a little bit, but it's really synthesizing in a compelling, very digestible way what these changes are, quickly developing the materials around educating how to document these new conditions, and making sure providers know what is no longer required to be focused on. And then having a conversation with your groups about, like, what does this mean for you guys? How can we help you be successful in this new environment? I think that question doesn't get asked of providers enough. And in my experience, they have a ton of responses to how we can help them. And so I'd say getting ahead of those conversations as quickly as possible is really important.
Yeah, I think Mark has a great point in that one. And another area where more on the payer side is more like workflow adjustments on some of these things, because you might need to see how you are enabling them, if you're targeting them from claim processing, or if you have any upfront data validations which you are rejecting your encounters based on the risk impacting conditions. Those things need to be realigned and work with the health plans or providers groups as well, because many of them, now that model will change, all of a sudden they see something has changed. They need to be prepared for that as well.
Definitely. Appreciate your insight, Siva. Appreciate your insight, Mark. We are up at time. So I want to thank all of our speakers, Mark Bigelow from Cambia, Rohit, our CEO and founder, and Siva, who is our Chief Product Officer. Please note that we are going to be at Rise National, and we will be presenting a roundtable discussion beyond compliance, transforming risk adjustment into strategic value, which will also feature our guest speaker today, Mark Bigelow from Cambia. So we look forward to seeing everybody in San Antonio. Have a great afternoon.
Thank you all. This was really, really helpful. Bye.